Well, good afternoon, everyone. Welcome to the last of all World Heart Federation Heart Cafe. And it is a pleasure for me to moderate the conversation today that is going to be in the topic of heart failure registries. Welcome, everyone. I am Francisco Lopez Jimenez. I am a cardiologist at Mayo Clinic, Rochester, here in the US. And it is a pleasure for me to present the three speakers or members of this moderated panel, and I will let them introduce themselves. We have Dr. Angela Cole, Professor Albertino Damasceno, and Professor Amitava Banerjee. Can you please introduce yourselves?
Thank you. Very privileged to be here today. I'm Angela. I'm a cardiologist, also a clinician scientist from Singapore, and also an associate professor at the Duke National University in Singapore. My research focus is in older adults with cardiovascular disease. I also lead a research group that looks into frailty, as well as digital health technologies for older adults.
Hi everybody, I'm Ami Banerjee. I am based in University College London. I'm a heart failure cardiologist and I'm a professor of clinical data science. So most of my research focuses on epidemiology of heart failure, from diagnosis through to palliative care and any form of management of heart failure. Really excited to talk on this topic from a global perspective.
My name is Albertino Damasceno. I'm a professor of cardiology in the Eduardo Mondlane University in Mozambique, Maputo. I've been involved with also a heart failure for a long time, since the first multi-country registry of heart failure in about maybe 20 years ago. I'm also the head of the Heart Failure Association from PASCAR, Pan-African Society of Cardiology, and I'm very pleased to be here.
Thank you. Well, I don't have to say much about the importance of heart failure, but let me just briefly say some high-yield facts that make this topic very relevant for all of us. In the USA, Europe, and many other countries, as well as low and middle-income countries, heart failure represents the most, if not one of the most expensive medical conditions. Just in the US, is the most expensive medical condition for inpatient treatment, and that represents a lot of the GDP that is spent in healthcare. So we know that there have been many randomized trials providing very strong evidence about what works and what doesn't work in the care of heart failure. However, as we know, those trials exclude many patients that are not well represented, and unfortunately those patients represent many times the majority of the patients we treat for heart failure. So as an adjuvant to the evidence for how to treat heart failure and how to better understand the condition, we recognize the importance of registries as a way to expand on the knowledge and also to provide real-world evidence about treatment, prognosis, and other indicators in the management of those patients. So, and therefore, the topic we are discussing today is on the basis of the relevance and the best next steps for the creation of sound and well-curated registries in heart failure. So, the way we will do this today, we will have some questions for the panel, and after we complete the set of questions, we will have some time for the audience to ask any additional questions, and at the end we'll finish with providing the high-yield take-home message for everyone out of this conversation. So we'll start with Dr. Cole. Angela, how do you think that registries in heart failure play a significant role in the care of patients with the condition?
I think in contrast to randomized controlled trials that you had mentioned, there are special subpopulations with heart failure that are not well represented in trials. I am very passionate about older adults and heart failure, for instance, and because that's the final endpoint for a lot of the age-related cardiovascular diseases. And a lot of times, you can't find actually data, or older patients are not actually recruited in trials. So registries are a very useful resource because they would be able to capture unbiased, real-world, individualized patient-level data. And registries, if they are properly designed, would also allow multiple time points to be documented in a registry, and that's really important because you have that time series kind of data that will be useful in tracking the outcomes, and also real-world prescription data to see if guideline-based medical therapy is being dispensed in your practice. And in Singapore, how we do that is that if we do have a registry, we actually have an opportunity to match that against national records. And that really provides that rigor necessary to match against national birth and death, so we can make confirmation about the cause of death, proper documentation of what that death is due to, the etiology of death. So that's really how we can make use of registry data to get really solid evidence that's in the real world.
Thank you. Well, following that great description of the potential benefits patients might get from registries, in your experience, and briefly, because this is a topic that could take 3 hours of conversation, what do you think are the main barriers setting up a registry in heart failure, and how can we overcome those barriers?
So while it's important, heart failure is also very complex. It is not a disease that's solely related to the heart, actually. We do realize that with heart failure, we've got multisystemic complications that determine their outcomes. So for instance, if they are frail, they may have a different risk profile or prognostic outcomes compared to somebody who's non-frail. There are also social determinants of health right now that's really important to be aware about, and that would affect how you want to prescribe certain medications. Socioeconomic factors are important as well, whether they can afford those medications. So heart failure is really complex, and heart failure registries need some pre-specified planning in order to be able to get all this information together. One possible way of overcoming such a problem, if you had not thought about it and then, you forgot to collect some variable and you want to think about it, really is to have an avenue to data mine from national records. For example, if there's a medical record system, you could actually apply artificial intelligence to do very purposeful data mining to try and overcome those information that you lack.
Well, we'll have more about the details on the barriers, but thank you, Daniel. That's a good way to summarize the potential challenges and how can we overcome those. And certainly those things are changing year after year. That now we have more tools for that, right? My final question for you is, recognizing the importance of international collaboration, how can we make those registries more international rather than just the national registry here, another national registry there, and everybody having their own small registry? How can we make this more global?
I think this is a complex question. I don't think there is a one-size-fits-all kind of answer to it. But what we can think about are probably, purposeful, pre-designed ways to actually build consortiums where, you identify certain sites or partners who have heart failure registries or have similar interests to put together a consortium and start to put that together. I would also suggests that given that a lot of the data now could be digitalized, we could actually have ways where we could do like a group analysis or individual meta-analysis within these sites. So there are ways statistically to try and make out more meaningful data together. So I think that there are ways to actually overcome some of these things.
Well, thank you. Let's now shift gears and ask a few questions to Professor Damasceno. Can you tell us a little bit on the current landscape of heart failure registries in your country or in your region or in the world that you are aware of? And if you can give us an example of a good case of a good registry available.
Speaking about my region in sub-Saharan Africa, there was very little information about heart failure, and I think that the first landmark study was the Heart of Soweto, done in South Africa by Karen Sleever a long time ago. And but that was a single hospital, the Soweto Hospital, and after that we have been able to organize a more wide heart failure registry, the THESIS study, about 20 years ago, that has been able to have 1,018 patients from 8 countries, several sites. For example, Nigeria had 3 sites. And this was important to know the reality of heart failure in Africa, which is, I think, a little bit different from what we see in other parts of the world, because it starts much earlier. It has a completely different etiology. Rheumatic heart disease is still a very important component. Dilated cardiomyopathy is also very important, and ischemic heart disease is still not very important in sub-Saharan Africa. But the trends are showing that there is an increase of ischemic heart disease. After this, I think that this study was important because it created the needs of other studies. Those are particular studies. For example, I remember that in Nigeria, 3 colleagues of mine have been collecting data on heart failure with a big sample. 1 in Tanzania, 2 or 3 in Ethiopia, 1 in Cameroon, but not as big as the THESIS. One institution that for some time has been pioneer in putting together people from several parts of the world and doing registries or even clinical trials is, I think, we have to talk about it, it's the PHRI. So I think that Salim Yusuf has this vision, and the Inter-CHF was the first registry that I remember that have participated. And recently, the GCHF, 23,000 people from 40 countries, more than 9,000 from Africa. It's really a huge work, and it's going to give a lot of information, recent information, because it ended with 2 years of follow-up 2 or 3 years ago, I can't remember. And I think that we will have a lot of information from the GCHF. We have done recently, we have finished collected data of the THESIS 2, and the THESIS 2 is also a registry that is widely represented in Africa, collecting data from patients that came on a single day with shortness of breath and taking the 7 days of the week independently and following them till discharge. I think that this is also going to be interesting, and the first results are going to be presented in the European Society of Cardiology in Madrid.
Good. Well, it's great to know that there are a lot of registries occurring, and that there are some of those that are international collaborations with large number of subjects. Have you seen any disparities in both the enrollment of subjects and also in the creation of the registries according to different socioeconomic levels of countries and even regions?
I think that we have to admit that if we do not do by ourselves, no one is going to take care of us. So we have now created a strong network of research centers, and the reason is mainly because people from the first world do not believe that we are able to bring good quality data. So they don't trust us. And we have to build up this trust, showing that really in sub-Saharan Africa there are research centers that can do not only good registries, but also very good participate in very good clinical trials. For example, 2 centers in Africa, one in Nigeria and one in Mozambique, have participated in the strong study that have changed the guidelines of treating heart failure. So, for example, I saw yesterday, this is just an example, not a registry, but a clinical trial that has start recruiting people for peripartum cardiomyopathy, but exclusively for United States and Canada. Well, I think that peripartum cardiomyopathy is not so common here, but it's extremely common in Africa, and probably the input from some African sites would be interesting for this one.
Absolutely. So there is clearly benefit in both sides, both directions, rich versus low and middle income countries, right? Not only contributing to data, but also the lessons learned go both ways. Good. My final question for you will be, what will be some strategies that could be implemented to overcome those disparities that are mostly socioeconomical, but some of those might be geographic, etc. In your experience, how can we overcome those disparities so registries become more inclusive and more representative of the world population?
I think that, well, in terms of financing, for example, I remember that we talked together about 3 years ago. There's not a single study, population-based study for the prevalence of heart failure in all Africa, not only sub-Saharan Africa, but even Northern Africa. We have applied for a grant to do such a study twice, and we have not been able to do it. Now we got some small amount of money to do just a feasibility study, and I hope that publishing the results of this feasibility study, we will be able to do the first population-based study in Africa. But the resources, the financial resources in Africa are really very small. People speak about giving priority to research, but this is just theory. In practice, there is no money at all. The second thing is the trust, like I said before. But the trust, we are building it up, and I really look forward that people will look to Africa in a different way, and they will believe that we are able to do the things right.
Good. Well, we have reviewed the potential benefits that patients can get from registries, the challenges getting those registries together, also how things might be very different in one region of the world compared to other, and the challenges in regards to the inclusion of countries and different people. Now, let's move on with Professor Banerjee. Did I pronounce that right? Yeah, okay, good. You know, we talk about the importance of this, but certainly there may be some ethical challenges or dilemmas that, in spite of the importance of those registries, what are the things that we have to be careful from the ethical standpoint putting together international registries, as we know that requires data sharing?
Thanks very much, Francisco. So problems with registries or any data collection can be from the consent through to the curation and collection, the curation of the data, how we analyze it, and how we interpret it. So first of all, is the data gathered as part of routine care or electronic health records? Is it a separate process to routine care? Who's taking that consent? And you know, clearly in the type of registries that my colleague is describing, that's all done, you know, properly and through an ethics board. But you'd want to check that that's done like in any study. And sometimes registries are being used as the basis increasingly for clinical trials as well. So you might get multi-level consent so that I can approach these participants later on to be involved in other studies. Then I think we need to keep participants updated and told about the results. But then in terms of openness and sharing of the data, this is a big issue that we need to try as much as we can to make the data available, not just the results, but also there are good examples now where if we can get even the metadata, the variables there, if I'm running a registry, it's highly likely that I'm not able to even pose all the questions, let alone answer all the questions that are possible in the registry. So, more heads are better than one in that respect. And then interpretation, dissemination. There are ethical issues about how we make sure that registries from the lower income settings of the world, we're able to disseminate. Our current structure of journals and fees for those journals does not support our colleagues in low resource settings to be able to disseminate their findings. How do we support them to do that?
Yeah, great points. Points that we sometimes don't consider deeply enough as we are putting together all sorts of registries, right? And we also recognize that the barriers are different from country to country, region to region, and that adds another layer of complexity. But in your opinion, what are the best ways to standardize data across different regions and different countries, recognizing that in some countries the causes of heart failure are very different than the main causes in other regions, and also even the nomenclature, and sometimes we get lost in translation because some terms sound similar but are not exactly the same. How can we standardize data collection so we can guarantee that we have what we meant to have?
Thank you. The largest effort to look at comparative epidemiology in the world, the Global Burden of Disease Study, didn't look at heart failure as an outcome for a long time. So the first step of standardization is to make sure that you're on the menu. and that's a starting point. You need to be there as a risk factor and as an outcome in this type of collection. And then this is what you've described is actually challenging, just defining the risk factors, defining the disease. I've been a consultant and attending for 10 years. Since I started my training, we have had at least 4 iterations of different global definitions of heart failure based on ejection fraction, based on left or right heart failure, and so on. And so how we keep up with our data collection so that they are standardized across is not a small task. And then you're right that risk factors differ in importance in different ways. The ESC and the AHA have published lists which are tens of risk factors. It's not feasible in every registry to gather all of them. So we need to have consensus about what are the top 5 or the top 10, and that should be locally informed. There's no point in Mozambique gathering data on factors which may be more suited to the London context. But I think another challenge there as well is that we have heart failure registries, but we're in the business of prevention, and so we need to think about the pre-heart failure. Which risk factors would we like to have in our registries, which are relevant to this audience? To think hypertension, ischemia, of course, but we just had peripartum cardiomyopathy. How often do we gather pregnancy history as part of our heart failure registries?
I mean, it's very clear that some things that we give for granted that means the same everywhere, just by the fact that different societies define criteria for specific diagnosis differently. That's also a challenge, right? The diagnosis of hypertension We don't really have completely harmonized guidelines or definitions between North America, Europe, and other areas of the world. So things that might sound very logical at the end might be also a source of discrepancies in how we define things, let alone heart failure and other things. We learned that when we were working on this AI ECG, that for people an ECG is an ECG, but when we talk about digital health or data analysis, well, there is this electronic ECG, there is this paper ECG, you have the raw signal, very, very different. My last question for you is, what are some of the current limitations gathering data that you can think about, and how can we overcome those limitations? Going to the practicality of gathering the data. So what are the main challenges?
I'll focus on three that we could talk about this for a long time, but I think the biggest ones are resources. So financial and human resources. That having the collection of the data, the curation of the data, interpreting the data costs money, and we have more of that resource in perhaps the places where there's less need, and we need to align that so that with the places where there's highest heart failure burden, highest heart failure mortality, we gather more data. And that's even within countries like the US or the UK. Often we've got more data from the tertiary center, academic centers, rather than the community-based, low socioeconomic status areas. Secondly, you need people. So particularly in the type of registry that you were talking about, you need research staff, research nurses, you need clinicians who are gathering the data and coding. And then I think the final thing is, you were alluding to electronic health record systems. So ideally, the ideal world would be where we don't need registries, where we can actually just take it straight from the water mains. But actually, that is a huge investment to improve our electronic health records and our data collection system, so that we don't, because in the long run, registries in all of our different diseases in a longitudinal way is not a sustainable way to do that. We need to improve our routine data collection.
Excellent. That was a very good review in general. Now, let's move on to the next phase, which is opening this to questions from the audience. I already have a few extra questions for you, but I would like to hear if there is any question from the audience. We have a microphone. Yeah. Please introduce yourself and spell the question. Thank you.
I'm David from Sheba Medical Center, Israel. I had two questions for you regarding data, for the most part. When you have a registry and you keep on uploading data, do you do it in a certain time frame so you could account for the gaps? For example, do you do quarterly or annually when you keep on adding new patients? So you could account for gaps and you don't have a few patients that are added and you have to do left truncation to account for when they came into the database. The second was, how do you account for changing, for example, the risk factors? You mentioned you have to account for the top 10 risk factors. But say, for example, obesity, which is increasingly important in the heart failure landscape, that wasn't, let's say, 20 years ago, and now it's in your database. How do you account for that retrospectively? If you take now the top 10 and they change from the top 10 that you had 20 years ago, how do you now account for it when you all of a sudden have it as your top 10?
Who wants to take it? Yeah, Angela?
Thank you for the question. I think I'll try to answer the first one. The first one is easier. I think if there is an existing registry that collects a particular disease, for example, heart failure. So where I practice, we have registries that collect based on disease. So heart failure is one, AMI is one, procedural such as PCI, CABG, ICDs is another, for example. And they are regularly updated, so we get meetings every 6 months, and we have a back end of resources and people updating those records. So that would be something regular to make sure checks are being done, new patients are being added, and also patients are also updated. If they continue to be in the healthcare system, they have that second, third time point. And so those risk factors, if they were to change, for example, his BMI was 20 10 years ago, and 10 years later his BMI is 22, that would be collected. Yeah. Does that answer your question?
Do you want to take on the second part, which
Yeah.
is, how do we account for new conditions, new risk factors that become more of an issue in recent years that were not collected before? Do we go back? Do we start from the moment we just start collecting that and don't look backwards?
What a great question. We'd all like to future-proof our data collection, but inevitably there's new data points. An example is that we now have such advances in cancer therapy that people are interested in looking at which cancer therapies are associated with heart failure, and cardio-oncology is a big thing. But the problem is our registries are in totally different buildings, let alone data points. And so how do we combine those? Often we can't go back and find those data points. You mentioned obesity. In the UK, we're lucky that we have a primary care health database where we can try and link retrospectively. But if you don't have that, then all you can do is prospectively gather what you need and try and compare going forward, or you can think what were the population trends at that time and maybe model in that sense, but you won't be able to impute the data like that. But yeah, I think this is a real challenge, and increasingly we know that heart failure patients very rarely just have heart failure; they have multiple diseases. So I think we need to think about how we look across diseases. Not heart failure and cancer is one example, but people are talking at this meeting about heart failure, kidney disease, diabetes. How do we make sure that those registries are also combined?
Good. Any other question from the audience? Yeah, we have one here.
Hi, my name is Faisan. I'm a clinical scientist from Abbott. And
Hold a bit closer.
is this better?
Yeah.
Okay. Sorry. I have a question regarding what you talked about. Ideally, we'll be tapping from the source, so from like EHR, and not relying on registries, ironically, when we're in a registry session. But what is the major challenge stopping us from like going to the source instead of, and why are we developing registries when we can go to the source? What's stopping us from doing that right now?
Okay. This is a 2-beer conversation. I can't finish it in 1 beer. So I would say first of all that the many of the places, whether it's hospitals, whether it's primary care, particularly in the most needy areas, don't have a reliable electronic health record system. Number one, and it's costly to in the US or the UK, after medical staff, electronic health records is maybe the biggest investment that a hospital makes. So that's a consideration. Secondly is that electronic health record system has to be designed and used for data gathering for clinical and research purposes. Much of our electronic health record usage is for billing purposes rather than for research. So we have to change that so that we have clean water in our system, not, to go with my analogy. And then thirdly, getting access to that back end of the data in the electronic health record systems. But when that all works across those 3 steps, then there's nothing like it, because you can gather real-time data, you can look at the trends, you can look at data that's relevant to the clinical practice.
I think that's a very good point. You know, I suspect that most clinicians and investigators around the world recognize the misperception of big data necessarily means good data, right? So big data can be pretty bad data, and that happens many ways, and oftentimes when we collect data relying only and solely on the EMR, because as EMRs are primarily set for billing purposes, um, some of the diagnosis rely on a code and not necessarily on a validated comorbidity clinically, but just, you know, is whatever the billing code was used right there, right? That might or might not be true. Um, I have a question for you. I don't know who wants to take into that, but uh, you know, registries take a lot of energy and effort, and sometimes registries are pretty ambitious, trying to collect every single piece of data for, in this case, heart failure. How can we keep participants, meaning investigators and clinicians, engaged and motivated when it's going to take, you know, 3 years perhaps to have the first publication out of it? That might be one of the tangible benefits people might get, what, you know, being part of this large scientific community that is publishing on the basis of this large registry. But how can we keep this motivation? Because I have been in many efforts of international efforts creating a registry in different conditions, and the main limiting factor is unmotivated investigators who just don't contribute. How can we motivate people for that?
Well, I can give you the example of PHRI. And PHRI has several, the Pure, for example. The Pure is now running for more than 20 years, and lots of papers are coming out. If we define in the beginning what are the rules of publication, and if everybody that contributes has the chance to be a co-author of a certain paper, people feel part of the project, and they really work. Also, we need to have some money to do regular meetings, at least once a year, normally using the big meetings, the ACC, the European College, the European Congress of Cardiology, and doing a meeting of the researchers that normally attend these big meetings. But my experience is with a very small amount of money, but defining correctly the rules of publishing, it's possible to have a huge, for example, the GCHF, 40 countries, several sites per country. It's a huge amount of people, and they have been collected 23,000 people.
Now, going back to your point of open access registries, could that be the disincentive for investigators? Because people might say, well, why would I just spend time if in 3 years I can just ask for access to this? You know, what is the right balance between open access of registries versus giving investigators perhaps the priority over data analysis and publications?
This is an important point. Firstly, there have to be, I think, the setting of ground rules and expectations. So it might be that you set a timeline where for the first year or 2 years or 3 years, there are landmark papers or protocol papers which the initial study team want to make sure that they publish. It may be that you make sure that the study team is involved in any study, whether it's as co-author or in terms of participation. And thirdly, to make sure, I think the biggest danger is, for example, if the type of registry that you have led is published, the people who gathered the data produced such a large effort in the low-income setting that doesn't end up getting published and exploited by places where the resource is. And so making sure that there's ownership there is really important. But to counter all of what I said, most of the open resources like this that have occurred, whether it's in terms of imaging, in terms of biobanking, whether it's in terms of data, have been hugely successful. And when you think philosophically, it's not your registry or my registry. It's the people's data. It's the public registry. I think maybe we need to change our thinking that it's actually a public good that's being done. So, I've been, influenced deeply by the UK Biobank in this respect. More is published from UK Biobank from outside of the UK than the UK, like by an order of magnitude, actually. But that's UK patients who keep updated of the findings. They can look at all of the findings on their website, and they know that that's happening, and they are happy with that. So if that's the case, then who am I as an investigator to be unhappy with that?
I would like something to add to this. I've got a very nice example. The stepwise approach, so producing data on the epidemiology of risk factors of non-communicable diseases. There is a small country, Cape Verde, that has done a STEP survey. 3 papers have been published. Not a single Cape Verdean author is a member of the authors. So 2 from Nigeria, 1 I don't know from where. I think that this is not fair, because the poor countries do not have the capacity to analyze. For example, one of our big issues is statistical analysis. I would love to have someone who could do the analysis. I mean, sometimes we have lots of data. I know that keeping data and not publishing it, it's not correct. But I don't believe in open data, because otherwise we produce the data and the other ones publish the papers.
Again, I think bottom line is that every registry has to have set rules of engagement from the very beginning, good stewardship of the data that is being used under several rules, and I think we all agree that priority should be given to the investigators who created the data, right? I will get back to your point of not using data in a moment, but we have another question from the audience.
Yes, a question or comment. Maybe if we talk about heart failure, I think the system failed. We failed in some point. The risk factors as Sayami, and so we failed because it's the end point. And the second point, I think it's very important for poor or low-income countries to have registry. It's not easy. I'm from Argentina, and I think the heart failure in North America is in Europe, it's another in the etiologies are different. We in Argentina have the Chagas disease, and I think in Africa there's another parasites and other etiologies. So the registry, I think it's very important to have data to appoint what's important.
So definitely another reason why registries, in one way can be international and representative of many regions, but each region has to have enough data to understand what is happening in that part of the world, right? Because even in South America, Brazil is not the same as Argentina, and that will take care of that. No, thank you. Thank you for that comment. I was about to make a comment that there is an American medical society that I will not tell exactly which one, but it's in the cardiology field, that put together a very comprehensive data registry. And even the certification of centers was depending, or partially conditional to the participation of the registry. But shockingly, I discovered that it took about 14 or 15 years of gathering data, lots of data from more than 2,000 places in order to produce the first paper. So almost 14 years to get the first paper. So I think there are ethical implications of all that amount of effort, all the voluntary work, and patients providing data when that data is not being used. So I think it's very important for us to recognize that when we publish, when we use the data, we are basically paying back patients, right, who participated in that, because at the end of the day, that's their data. It's not our data. It's their data they are sharing with us. And therefore, the more we publish and produce out of those registries, the more we use the results, the better we serve the purpose of the registry, and the better we pay back the patients who were participating in those trials. Good. Any other question from the audience? Well, if not, I will just ask the final question. If you can tell me, each one of you, what do you think is the single most important message you want people to take home in relationship to heart failure registries, specifically international heart failure registries?
I think in my mind, based on what we've discussed so far, I really think that for the initial efforts of setting up a registry, for its objectives to be realized, I think long-term sustainability is really something that should be considered upfront. And I think if there is a registry that is of national interest, there is a higher chance of it to be continued over years and years and years, rather than just depending on ad hoc funding. So I think that would be the most important take-home message for me.
Thank you. Amit?
I think you made some really interesting and instructive comments about how PHRI and the registries you've led have worked. I think engagement and I mean of both the investigators and but also the patients and the participants, because we focus often on how good is the data and how clean is the data, but if we don't keep the people who are collecting the data and leading that data collection engaged, then the registry will fall down. So keeping everybody engaged, including maybe the patients, because they, as you say, we need to communicate the results of the registry back to them eventually.
Well, in my opinion, I think that the funding agencies should look a little bit more to the places where data is needed, and probably to provide money and to make it happen in parts of the world where we don't have data.
No, thank you. In my opinion, starting a registry is similar to planting a tree, right? The perfect time was 20 years ago, and the next perfect time is now. So for those who don't have a registry, a national registry, it's better to start late than never, and to have your own data. Well, thank you all for this great discussion, for the amazing pearls of knowledge, and thank you.
Thank you very much.
Thank you.